Well, thank you very much indeed for that very nice introduction. So nice to see so many people here on an evening after a hard day's work, presumably, and very nice to see so many faces. It's a very topical subject that we're talking about this evening, laser refractive surgery. I suspect that many in this room are directly involved, and some will be part-time involved, and some possibly full-time involved. But I thought I'd try and just give an overview of where we've been and where we are at the moment, and perhaps what's happening in the future. Some will be aware that just over a year ago, it was the 50th anniversary of lasers in general, the very first lasers. And medicine and surgery have been intimately involved with laser applications ever since. In fact, I think I'm right in saying that ophthalmology was the very first medical specialty to have used lasers at all, and that was in the treatment of diabetic retinopathy. In the days of radial keratotomy and other forms of refractive surgery, it was hoped and felt that could we only just have some computer-controlled refractive device, then we could get away from a lot of the hard problems or the more difficult complications that we had with previous techniques. And it was this magic of laser that somehow it could be computer-controlled and give rise to some wonderful reprofiling of the cornea that led to the early work in laser refractive surgery. Some of these slides will be familiar because they're very historic, and this is actually from Srinivasan, who was an IBM specialist in New York, who first suggested that it was possible to use these excimer lasers to carry out corneal surgery. And he went down the road to Cornell University and spoke to Steve Trakell, and the two of them decided that it was a possibility. After all, perhaps we could use these extremely precise lasers to produce an effect on the cornea similar to radial keratotomy. And in those days, the thought was that perhaps we could do incisions with the laser in the same way as the surgeons who'd done radial keratotomy produced these radial incisions. And in fact, the first refractive treatments were radial incisions. But surprisingly, it wasn't so accurate at putting cuts into the cornea as it was in reprofiling the surface of the cornea. And you can see a single pulse of laser energy here, where a laser beam has been fired onto the corneal surface. You get this cloud of debris coming off. And Carmen Pugliafito was one of the very early workers in this field. Now, this is Carmen here. Steve Trakell, Ron Kruger, John Marshall, who I'm sure a lot of you will know, and a good friend and colleague of mine at Moorfields, Steve Tuft. Some very familiar faces in this audience. And if patients say to you that laser hasn't been around long enough and it's still experimental, well, this is the very first workshop in 1986. By my rather poor maths, I reckon that's 25 years ago. And here are the three main pioneers of the era, back in the late 80s, Steve Trakell, Theo Zeiler, and John Marshall. And I had the pleasure of working with John Marshall for several years in the early days. The first PRK, which I had the privilege to carry out, was at St. Thomas's on November 1989. And we had an 20th anniversary dinner down near St. Thomas's with my two colleagues at the time, Malcolm Kermure and John Marshall, and yours truly there on the right-hand side. Now, those of you who know John Marshall know that he's pretty much ageless. He was supposed to have retired 2 or 3 years ago, but guess what? He started to work at Moorfields in the Institute, working just as hard as ever. So he's never going to retire, and he looks about the same as I recall from the 1980s. Unfortunately, the same can't be said of myself. It's very cruel when people laugh at that, it really is. So this is an excimer laser pulsing away on the surface of the cornea, slowed right down so that you can see the fluorescence. This actually, strangely enough, as you might imagine, is a toroidal treatment. It's toric, and so it's actually a linear treatment that's being performed there. But that's a PRK. In the early days, we couldn't do lots of things. We could treat simple myopia after a fashion, but we had none of the above. And you'll see as I go through this talk that we now, of course, have all of the above, including extremely sophisticated tracking systems that involve photographing the iris and analyzing 3,000 points on the iris in a similar way to the iris scanning at Heathrow for security purposes. And we use these iris recognition software programs to make sure that we're always treating the correct eye. It's important, but also so that everything's lined up perfectly on the front of the eye. Our original method for tracking was actually just putting both hands either side of the patient's head and keeping them in the right place while the laser was working. That was 1989. Well, of course, the lasers themselves have improved dramatically, and so now we no longer have these small diameter spots. We no longer have single broad beam lasers. We have all sorts of bells and whistles. But even today, with current state-of-the-art laser refractive technology in whatever form you might believe in, we still are struggling with individual wound healing variation. When I'm counselling patients about the whole thing, we tell them, of course, the excimer lasers are very accurate, the computing side's very accurate, the physics, the maths, even the chemistry with the eye drops is very accurate. But what's not so accurate is how they will respond to the laser treatment, how they will heal, how will their keratocytes behave once you've actually carried out this treatment on the surface of the cornea. Which is why it's always very surprising to me to find various reports of 98% of patients having 20/20 vision or greater unaided. It sort of defies, in a sense, the wound healing situation with the corneal surface. The early days with surface treatments, PRK in particular, we tended to get a combination of factors that tended to cause the effects to wear off. So we had a healing process going on in the cornea, which then caused stromal scarring or haze in the cornea. There was epithelial hyperplasia, and the cornea was basically trying to go back to what it had been like before. And this is one of the classic slides from when I first started at Moorfields in '92 of significant corneal haze following a PRK surface laser treatment. Now you might imagine that the vision there would be extremely poor, but you have to remember, as some of you will know, that this is really very similar to a net curtain, and the vision is not as degraded as you might imagine, in the same way as you can look out from a darkened room into a brightly lit street, and you can see what's going on in the street relatively well. This is the same idea. You can have quite significant corneal haze, and the patient will still get 6.9 or 6.7.5. Hardly ideal, but not as bad as we might have thought. And having mentioned Steve Tufte already today, once, this is one of his slides which shows the extra material that's laid down in the cornea following on from a PRK surface laser treatment. So all the cornea is trying to do is go back to the shape that it was in before. And the thickened epithelium also creates the same effect. So not surprisingly, if we treated relatively high levels of myopia, we would find that there would be an initial overcorrection followed by a regression to an undercorrected mean, in this case around -3, -4. So it became fairly apparent early on that this would work better for fairly modest amounts of myopia. A professor in Crete, in Heraklion, called Yannis Palikaris, in the early 90s, 91 or 92, described or suggested the possibility of splitting the cornea, as we would do with lamellar corneal grafts, and doing the laser surgery inside the cornea. And this is how the concept of LASIK was born, the idea that you could produce a corneal flap, lift the surface of the cornea away, do the treatment inside the corneal stroma, and by doing that, you isolated all of these wound healing factors. You stopped the corneal haze, you stopped the regression, the loss of contrast sensitivity. You answered one of the key problems of PRK surface treatment. Now I'm going to show you this video animation from a friend of mine in Chile, Santiago, not because of demonstrating the corneal flap. I want you to look at the artistic license at the very end of the clip, because this has to have been rendered, CGI, and when he puts the flap back down again at the end, there's a little flurry of activity with the spatula, which must have taken quite some time to do. So I'd like my colleague in San Diego to be appreciated for this extra work in producing this animation. This is meant to be, of course, the ultraviolet light of the laser, and here you'll see this little tiny tap there on the cornea, which I couldn't have done any of that, let alone the extra flurry at the end. Well, we know that LASIK has subsequently taken over. It's not quite the commonest eye operation in this country or in the world. It's the second commonest eye operation, the first being phacoemulsification cataract surgery. The figures differ, but around 350,000 cataract operations a year in England and Wales, around 130,000, 140,000 LASIK-type refractive laser treatments. And the third commonest operation in this country, coming in at around 100,000 per annum, is artificial hips. So because we've done all of this work, and because all of these patients have this surgery done, we know an awful lot about it. And I think, in brief summary, it's fair to say that it works jolly well for relatively modest amounts of myopia, as long as the prescription's not too high, and we know all about the complications and how to try and avoid them, and I'll come to that shortly. So the advantages of LASIK was very, very simple. There was no or virtually no corneal haze, very rapid recovery, because you weren't taking the corneal epithelium off, much more comfortable. Patients go back to work occasionally the next day, but we normally recommend 48 hours. And you didn't get this haze, and so you could extend the myopic and the hyperopic range to a degree. It's default now for both eyes to be treated at the same time, but it's been default for the last 10 years. It's been absolutely the norm. At Moorfields, we went through a year or two where we were treating around 2 weeks between the two eyes, and we looked at several hundred patients coming back, and they all had the second eye treated. We can still occasionally do a separate treatment. We don't have to automatically do both eyes together, but that's really at the patient's request. There's no particularly logical reason for not doing both at once. As long ago as 2001, 10 years ago, wavefront technology was added on to what we'd been able to do before. And the concept was simply that your refractive error comprises primarily your sphere and sill, or if you're lucky, no sill and just sphere. But there are other high-order aberrations in the powerful plus 60 diopter human eye optical system, which will have an effect on things like night vision and the overall quality of the final image. And the idea with wavefront was to try and give you that extra dimension. Of course, at the time, immediately the newspapers jumped on this, and they decided that Richard Branson had had wavefront-guided laser treatment, and now he was 2015. But in fact, he hadn't had wavefront-guided laser treatment. This is a library picture, I suspect, and he'd had treatment a few years before with a standard LASIK procedure. And this young lady on the right-hand side, she was a Moorfields patient. She'd had problems with her cornea for other reasons. I'm not too sure what they were, but she's described now, having had wavefront-guided laser, as having the best sight in the world. She was 6'9" part. Wavefront is very simple, and it's much easier for us to describe this to an audience of optometrists than it is to describe this to an audience of doctors. Because any high-powered optical system, the object that you actually are imaging with that optical system will produce an image, and that image will be a direct result of the quality of the optics. Hence, huge telephoto lenses have got massive numbers of optical elements. I don't need to say any more to this audience. But you don't necessarily get the image that you want when you have a highly powered optical system. So wavefront technology is basically a very, very sophisticated retinoscope. And it does exactly the same thing. A light beam is shone onto the retina. It's gone through the eye once to get to the retina. It's reflected back out of the eye a second time. So it's a double pass, and they have to take that into account when they're calculating aberrations. And if you then allow the light beam that's coming out to be carefully analysed, you can pick up the short sight, the long sight, the astigmatism, and the aberrations in the system. And that's what wavefront technology does. It's like having a highly sophisticated retinoscope and an objective measure where you don't have to decide yourself on exactly the width and the against or the scissors movement. It'll do it all for you, and you can document it. This is a typical wavefront scan from AMO Abbott's VISEC system. This little point spread function here is basically just the higher order aberrations only. This patient is around -8, and if you had all of the aberrations, including the sphere, you'd have a complete large circular black splodge on your chart. So we know that somebody who's -8 unaided is going to have terrible vision, except at about 12 centimeters away. But this is just the higher order component of their visual quality unaided. And this is what we're trying to treat with wavefront. We're also trying to prevent aberrations being induced by the laser as well. But the important point is that if you look at a percentage, 3.1%, that is the blur that the patient gets from their higher order aberrations. The other 97% is sphere and sill. So it's not a huge amount. And yet the newspapers and various sources were talking about supervision because it was mainly in theory that would occur. In order to get very, very good treatments, you have to be very well registered on the cornea. And this little animation is just meant to demonstrate the effect on point spread function or letter chart. If you don't have your laser beams well and truly locked on in the right position. So in order to get any benefit from wavefront, you need to have a very well-registered treatment. If you treat a little to one side of where you intend to treat with the laser beams, you'll actually induce more aberrations. You'll not reduce them at all. Very important. And so a lot of work was put into trying to take photographs of the iris, analyze the iris crypts, the pigment, perhaps 20 features on the iris, and then once the patient was underneath the laser, that would be recognized again. So the laser could line itself up, and there's a very rapid scanning system which will allow the tracking system to sort of compensate for small differences in rotation or X and Y and Z. But that's actually then moved on to the system that I use now at Moorfields, which relies on the Heathrow security system of iris recognition. Instead of 15 to 20 points on the iris, it's now 3,000. So you can't treat the wrong eye, you certainly can't treat the wrong patient. Absolutely not. It's 1,000,000 to 1 chance that the iris features will be exactly the same when you're looking at 3,000 points. This is just a little video clip just showing how we lock on from the iris recognition point of view. And it's a handheld camera that my colleague Alan Lacey at Moorfields is holding for us. We're very good at sort of taking pictures down the microscope, but we're not so good at actually having an overall view of what happens when the patient goes through the process. This actually shows that we have originally locked on with the patient in just the right position, with their head in the right place, and there was hardly any error at all in their alignment. Now, this doesn't often happen because ordinarily 2 or 3 degrees either way, the patient might have tilted their head. And when you do the wavefront scan in the clinic, they're sitting up, and they may well have tilted their head slightly when they had the scan done. Now, the laser compensates for that, so you don't always see 0 degrees perfect alignment. But once you've got the patient lined up underneath the laser, you'll then be able to follow this treatment line as it's running, and you'll see tiny little microsaccades as the patients automatically, they can't help moving a little bit, and you'll see the laser compensates for that until you get to the end of the run. This system will compensate for 15-degree rotations, and it'll still not be beaten. So if the patient has somehow in-cyclo or ex-cyclo torted, which can happen when they screw the other eye up. When you're treating the patient, one eye's covered, the other eye's looking at the target. But if they tend to sort of close one eye quite tightly, the other eye will do something funny if you're not careful. So this is an excellent safety guard. I mean, there's no question that this has been a very big improvement from our point of view. As long as you have 3 green lights here, it means that the laser is compensating for your movements of the patient. In fact, I think it's fair to say there's far more movement in the camera than there is in the actual tracking system. But as long as this line follows the sort of more or less between these 2 dark blue lines, you're happy. And in fact, it's very close to the median line. This is exactly where you'd like it to be, tracking along until you get to the end of the 45 seconds. You can't do wavefront guided treatments without this sort of system. You have to have a way of registering the treatment in exactly the right place on the cornea. So, results nowadays. Because we've been doing it so long, we ought to be able to constantly update our results and make things more and more accurate. We probably won't get rid of the final corneal wound healing problems, but we can look at old results from the year before and change our results going forward to make sure that we optimize the results for the patient. And this is called algorithm adjustment. And it's basically a concept of trying to hit the target even though you can't control corneal wound healing to the nth degree. You can see from this graph that this line is almost 45 degrees. What we've done here is we've plotted the attempted correction against the correction that was actually achieved. And if that line there had gone through that point there, it would have been 45 degrees, and that means that you put -6 in and you get -6 out. Well, that's not the whole story, because you don't always get -6 out, and in fact, you do get quite a bit of spread in the data. There's about 2,000 data points here, roughly, approximately, over an 18-month to 2-year period. The green dots represent plus or minus a half, and the red and blue are within plus or minus 1. If you actually make it a bit more appealing to the patient, you can actually make a lot of the green dots appear by saying, if you're within plus or minus 0.75, then you'll have a green dot. But the point I'm trying to make here is that that is almost 45 degrees, but what about the spread in the data? The slope of the graph is fine, but what about the individual points that are spread around? Can we do anything about that? When you hear these wonderful statistics claimed of 98% patients 20/20 or better unaided, it usually means a fairly selected lower age group with a relatively modest prescription, and it often includes retreatments, and it often, well, I think it always excludes amblyopic eyes. I mean, why would you put an amblyopic eye, 6/9 at best, into your statistics to say that you hadn't been able to achieve 6/6? You never would have done. So these types of statistics are very finely tuned to optimize the percentages. But my best efforts of producing graphs to my heart's content, I can never get it past 95% in my own hands. And that's someone who's done it for a long time, who carefully, rather obsessively follows all of the patients themselves. But this is just to show you the difference between simple myopia, where this line is very respectable, it's pretty much 45 degrees, and compound hyperopic astigmatism, which apart from mixed astigmatism is probably the worst refractive error we try and treat. Relatively few numbers here, but you can see the overall pattern. This is definitely undercorrected. When that line on the graph is less than 1, when it's less than 45 degrees, it means that we've been undercorrecting our patients on average. When it's beyond 45 degrees and the slope of the line is greater than 1, we've been overcorrecting them. And this has all been well sorted out now. If you want to achieve exactly that 45-degree line the following year, you need to look at your patients from the past. And if, for example, they were all coming out in this region of the plot, you can sort of fairly simply state that the majority, or if not all of them, have been undercorrected. What you would like to do is to actually have them all along this line. This is the regression line that goes through the points that you have on the graph. So this is a statistical way of representing those points as an average. You're getting the best fit straight line through those points. And it shows you how far away you are from the purple line. And the maths of it, which is basically just the mathematics of a straight line graph, will allow you to either boost or deboost. You can actually set the laser the next year to compensate for this deficit between these two lines. And that's really one of the basic ways of adjusting the slope of the graph and adjusting the algorithms for the years ahead. There's also another constant involved, which is actually to do with the intercept on the y-axis. So it's not just changing the slope, it's also changing the position of the line by altering the intercept on the y-axis. But you'll see, very familiar, of course, from GCSE. I nearly said O-level there, but GCSE. Y equals mx plus c, it just works on the basic straight line graph. It can be much more complicated than that. We can do multiple regression analysis on the data points by looking at particular things that might affect the data. So for example, instead of just looking at refractive outcome versus intended, you might say, well, I think that keratometry is very important. Steep corneas are more difficult to flatten. Flat corneas are a little bit easier to steepen. Hyperopic patients with a flat cornea are easier to treat than hyperopic patients with a steep cornea. There's no question that intuitively, keratometry should, you think, help in predicting how the patient's going to work out. So that's what you do. You feed in factors that you think intuitively might be important, and you do a very complex 3 or 4 or 5-way regression of analysis, and the statistics will tell you how important that particular factor was in predicting the outcome of the patient. And then you can actually do something even cleverer by feeding the maths back in, reworking the algorithms, and the next time you get a patient with a steep cornea who's +3, it does something slightly different to what it had done the year before. So it can get, as complex as you like on the maths side of it. I don't pretend to understand all that, but there are programs that will do that for us. And one of the lasers that we use at Moorfields has it built in already. So all you have to do is press a few buttons and it will produce the optimized treatment that you need to put into your laser. Just to set the scene a little, we're going back a couple of years now to 2009, but that's for a good reason. At Moorfields, this year I think we're heading for around 4,500 treatments. In 2009, during a bit of a recession, we treated 4,150 patients. And of course, not surprisingly, 93% are private treatments, with 7% being NHS. The vast majority are intra-LASIK with the femtosecond laser. Even in 2009, we had given up on the mechanical microkeratomes, and we no longer had a service contract for them. So around 3.5 years ago, we switched to femtosecond laser to create flaps, which means that the other group is the relatively smaller percentage, patients having surface treatments and LASIK. These figures, by the way, are for all 8 consultants who were working in the refractive service at that time. We also had 2 brand new lasers, a brand new AMO Abbott Star S4 laser and a brand new Technolas Perfect Vision, formerly B&L Z100. And it was very interesting that I went through a year or so using them both. It's a very unusual thing because normally, of course, any individual practice will just have the one laser. They might change to a different one later, but they're unlikely to be running 2 different lasers in the same department in separate rooms. So we looked at this and we tried to work out if there was any significant difference between them. And bear in mind that they were both brand new. They were what you would call just out of the box. And so for about a year, I just alternated between them. I think, for example, for sake of argument, Saturday patients were treated in the AMO room and Monday patients were treated in the Technolas room. It wasn't exactly a randomized controlled trial, but then on the other hand, that's actually very difficult to organize on the private side. And this is my colleague at Moorfields, Miss Linda Ficker. Now, some of you who are very observant will realize that Linda's got a bit of a problem here, because not only is she wearing what looks like intermediate, but she's also got some reading glasses for when she's actually treating the patient. So Linda is very keen on any research that goes into presbyopia and particularly intermediate vision. And this is the other room that we have, the Technolas Z100. This is the laser that has the dynamic rotational eye tracking with the 3,000 points on the iris. Now, there's no need to read all of this. I put these slides up just purely to show you that we have very good programs now available to allow us to analyze the data. As long as, of course, we've got good stuff being entered in. The IBRA program, which is designed by a colleague of mine in Manchester, Bruno Zuberbühler, it's an internet-based program which allows us to enter all the data in, and then ultimately, at a few keystrokes, you can produce these wonderful tables which will tell you all about your simple myopes, compound myopic astigmatism, right the way down to your your mixed astigmatism groups. And of course, we can compare the 2 lasers fairly readily. And what it turned out to show was that with our 2 brand new lasers, the Technolas Z100 was statistically better than the Abbott AMO. Now, if you left it at that, it would be very, very misleading. Because as they were brand new lasers, we weren't sure whether one was going to undercorrect or overcorrect. You just don't know. And once we'd factored in the undercorrections on the Abbott AMO laser, that was back to normal again. The message here is that you must carefully review your outcomes within a reasonable time frame. Don't do what we did, which was wait for a year. If you've got a new laser, you need to be constantly monitoring the results of the first patients going through, even if it's only the first 50 eyes, to get some idea if you've got an undercorrection or an overcorrection, or if the astigmatism is worse than it was before. It's all to do with careful monitoring, particularly with new software changes, or with brand new machines. And I wanted to spend just a little time, 20 minutes perhaps is all I've got left, talking about avoiding problems, because the name of this game is avoiding problems. Those of you in the audience who counsel patients for laser refractive surgery, and some who may be under some pressure to move on and to refer the patient on and to get on and do the treatments, will know that you can pick out patients who you can put off because you know that they're not going to be happy whatever you do. Of course, you've got to know about your results, your myopic results and your hyperopic results. You can't counsel someone who's -10 in the same way as someone who's -2. And you can't counsel someone who's 50 in the same way as you would counsel someone who's 25. So we take a lot of stuff into account here. And the big one here, as far as I'm concerned, is presbyopia. Because we'll regularly have patients coming who are -1.5, -2, and they're 45, or they're 48, or 52. And you say to them, now you do realize, of course, that you're going to have reading glasses afterwards. And you'll get one of 2 replies. You'll get, oh yes, I knew all about that. I've got reading glasses when I wear my contact lenses. I mean, I've had them for quite some time. I get those ready-mades one over the counter in Boots. But they've forgotten something else, that they often read unaided. So they might well put their reading glasses on when they've got their contacts in, or they may have varifocals or bifocals. But they forget that they read in bed with their -2. And the contact lens practitioners will know all about this. It sounds self-evident now, but in the early years, it wasn't so self-evident to us. Now, in order to avoid disappointing the myopes by making them long-sighted and they're already in their 50s, of course you would tend to aim for slight residual myopia. If they end up slightly more myopic than you expected, you can go back and do a bit more. It's not the end of the world. In my own practice, around 3% of patients have an extra treatment, and it's almost always for refining the refractive result. Hypermetropia is more difficult to get rid of in the first place. So for those patients, we tend to try and overcorrect slightly. We try and go slightly over and we expect them to regress a little bit. Age and occupation goes without saying. You've always got to take that into account. And another problem that patients have after laser surgery, which they hadn't fully intended to or hadn't expected, is intermediate vision. Again, the contact lens practitioners will know when you take them out of their glasses and put them into contact lenses, if you've got an equivalent prescription for them, it might tip them over the edge when it comes to reading. Their intermediate will certainly suffer, and they won't be able to focus in as close as they could before when they had their specs on, as you know very well. Plus the fact that they sometimes slide the specs down their nose to get a little bit more pseudo-accommodation. All of these issues are important when you come to counsel patients for laser refractive surgery. The average age of the patients coming through in my practice, and pretty much it's the same for Moorfields as well, the average age is 37 for the myopes and 52 for the hyperopes. And when we heard that figure of 37, we thought it was wrong. We assumed that there'd been some problem with the stats, but it's absolutely correct. It's not the 25-year-olds on average that come forward for the surgery. Perhaps they can't afford it. That's a factor. But the reason that we have an average age of 37 for the myopes is simply that they're running out of steam with their contact lenses. They can afford it, is another reason. And they're getting towards presbyopia anyway. So we've actually had patients in their 40s and 50s who've become obviously presbyopic, and the last thing they want to do is to have two separate pairs of spectacles or contact lenses and readers. And so they say, well, to heck with this, we're going to get rid of one problem. I'm very happy to have reading glasses only. So those two big factors push up the average age for the myopes. Monovision, you'll know full well, is very important. I'm sure you've tried it in many, many occasions in practices. But I'll never do monovision with laser unless the patient's tried it first with contact lenses, even if it means sending them off to their friendly optometrist to have a little supply of disposable contacts where they can at least try them. You've got a problem with someone who's contact lens averse and won't even try them on an experimental basis. But in general, you must have a contact lens diagnostic trial first. Now, for the sake of time, I'm not going to go through all of the different possible health aspects: systemic disorders, connective tissue disorders, dry eyes, Sjogren's, rheumatoid, systemic lupus. I'm going to pick on slightly more ocular problems, such as pathologic dry eyes. Now, we have a lot of patients come to see us in the refractive service at Moorfields whose optometrist has told them that they can't wear contact lenses for much longer because they've got dry eyes. And the optometrist has often measured that with Schirmer's or tear breakup time. But you ask the patient, how do you feel when you're wearing your spectacles? And they say, absolutely fine. I haven't got a problem. My eyes are a bit dry when I've worn my contact lenses for 26 hours a day, all day long at work, and you get to that evening period when you want to take them out. But that's not the same as pathological dry eye from our point of view. Dry eyes are notoriously difficult to measure, as you know, and you must have had lectures by experts on dry eye, so I'm not going to step on anybody's toes here. But as a clinical test, if they feel perfectly happy with their spectacles and they do not have dry eye symptoms with their specs, then they should, in theory at least, go back to that position a few months after having had laser surgery. They might have dry eyes a little more than average in the first few months, but in my experience it settles back down to normal once the corneal nerves have recovered. So dry eyes are one of those difficult areas when you're counselling patients. We don't treat patients who've had a diagnosis of glaucoma or a diagnosis of serious ocular problems like retinal detachment or previous diabetic retinopathy treated, and only eyes. Now, you'll know full well when you're prescribing spectacles and contact lenses for patients who are amblyopic, the dominant eye has got to be perfect. Nothing else will do. If they were 6'5" with their old glasses and they're 6'6" with their new ones, they're coming straight back to you. Whereas if both eyes achieved 6'6" and binocularly they were 6'5", it's not so much of a problem. And it's the same for laser treatments. If you're willing to take on patients who are amblyopic and you don't manage to make the dominant eye as good as it was before, you're in trouble. And the point about facelifts is actually slightly tongue-in-cheek, because facelift patients can have a slightly overdone effect, blepharoplasties as well, ptosis operations, and they can have trouble with long-term dry eyes. What to avoid? Well, try and avoid the young, fit 26-year-old rugby players who come along with their mother to the consultation because they faint. And don't let them come in to watch their girlfriend being treated because they still faint. And the other problem is that with health and safety now, we can't pick them up because they're huge. Very important when you're thinking of treating someone, take a contact lens history. If they couldn't let the optician get a lens near them, they're going to be much more difficult to treat when they come to have their laser surgery, as night follows day. Sometimes, of course, they've given up on contact lenses because they found it very difficult themselves, insertion and removal. And it's a very practical point. It's a bit like one of the useful tests for seeing if someone will be quite good with laser surgery is tonometry or pachymetry. If they can have a contact on the eye with anaesthetic without fainting and throwing a wobbly, then that's a good sign. When we do bilateral simultaneous treatments, which we normally do, we always do this, well, it tends to be the right eye first, just purely by, just habit really. But the left eye or the second eye is often more difficult to treat. And there are a couple of reasons for that. First of all, they've had the right eye done already, and they can't quite tell whether it's open or closed. And you'd like it to stay open to relax the left eye. So they're probably sort of underneath the covers, they're probably screwing up one eye for all it's worth. And the second reason is pharmacological, because the pharmacological experts tell us that when you've had one eye treated, you've used up some of your adrenaline and some of your endorphins in the angst and the anticipation before you've had the first eye done. There's a dip in the levels of those neurotransmitters, and you end up feeling the second eye more, which apparently is the reason why you feel a second filling more than the first. And if you have a blood test where they miss the vein in one arm, it'll hurt more when you go to the second arm. It's interesting. But it certainly fits in with the clinical picture. Things to avoid, of course. This patient developed corneal ectasia. This is actually from a colleague of mine in Atlanta, Georgia. And this patient was sent to him for treatment. Of course, nobody ever puts up their own complications. You'll be aware of that. You've always got somebody else's complications. And I've certainly had 5 or 6 patients with ectasia of my own. I hope we've managed them as well as we possibly could, but this was in the early days when we weren't quite so attuned to the risk factors for ectasia. So this is 6 months after laser surgery, but if you look at the pre-op, you'll see that there's something going on here. These are very old ARP scans, but it shows you that there's actually either forme fruste, or Steve Tuft, who's a keratoconus expert, would have said this was actually established grade 1 keratoconus. Now, of course, we've got all sorts of all-singing and dancing topographers that will give us the story. The Pentacam, with the latest Bell and Ambrosia software, will flag up whether the patient's got the slightest chance of having early keratoconus. There's a computer program that does the work for us, and there's a red box that comes up on the chart to show us that this patient is at risk, and not to just go ahead and do laser refractive surgery regardless. So you've obviously got to make sure that the topography is normal. You've got to make sure that they've got sufficient cornea, central corneal thickness, to be able to take whatever laser treatment you're proposing. More difficult if they've got thin corneas and they're -8. Femtosecond has been a very big advance for us because it's meant that we could produce thin flaps of very consistent dimensions, both diameter, the edge profile, the thickness of the flap, and the flaps are also absolutely uniform in their contour as well. They don't get thinner in the middle and thicker at the edge. And this is an example of corneal OCT, an OptiView OCT, and this is actually done with a standard mechanical microkeratome. And you can probably just about see this little yellow bar is the base of the flap. So this is tear film, this is epithelium, and this along here, I hope you can see that. Is there a juncture there that you can pick out? That's the bed that was treated, and you can see that the flap is 178 microns and the bed is 351. So considering at the time that this was done, we were leaving about 200 microns in the bed, this is actually a very safe corneal bed. And I'm very pleased to say that it's very safe because it was my own LASIK. These scans were taken a few months ago, but I had my own LASIK almost 11 years ago to the day in October 2000. I don't know if you recognize my surgeon. I've had no follow-ups whatsoever. Difficult to get follow-ups when you have it done in Houston. But this is Jack Holliday. You may know him very well from all of the amazing work he's done on biometry and intraocular lens power calculations. He's really quite special. Of course, if you really need to, if you want to avoid any of these problems, the cornea is a little thin. It seems to you as though it's a normal cornea, but it's just a bit on the thin side, and you're worried about the residual stromal bed. You want to leave enough cornea behind. Then, of course, you can do something very similar to a PRK, and some surgeons still do PRK. It's a very good technique. It's painful, and you've got haze and all the rest of it. You can minimize haze nowadays in surface treatments with mitomycin C. That's a little controversial, but it's something that I do myself. So once you've actually scored the edge of the epithelium that you want to remove, this is alcohol that's been applied to the cornea, by the way, 20%. You can then push the epithelium away and get down to the Bowman's layer and then do your laser and press on from there. I won't bore you with the laser bit of this. Femtosecond flap creation. This is a very early video from a few years ago, 4 or 5 years ago, a demo video where the flap is created from the center of the cornea outwards. So these little pockets of plasma are being created in a corneal plane. The cornea is being flattened by the applanating device, and these are tiny little minute bubbles of gas produced in a flat plane across the cornea until you get to the edge of your flap diameter. Then you have a further side cut that goes all the way around, except for the hinge. So this is left blank, and then you've got a beautiful corneal flap, and you can do anything with this. You can even set the profile of the edge of the flap to anything you'd like. It can be vertical, it can be slightly undercut, chamfered, and so femtosecond technology, there's no doubt about it, is here to stay. This is the one at Moorfields. This is just myself using the femto. This doesn't go from the center out. The AMO Abbott IFS femtosecond laser works as a sort of a tiny raster of treatments going across from a sort of a plane from below. It looks as though it's going from below up. You'll see a much better view in a second or two. Just getting it absolutely right. The cornea is applanated, and this is the raster pattern of minute plasma bubbles that's working its way across the cornea until finally you get to the other side, and then it creates the side cut for you. You can just about see the glow around the edge as it's done the side cut. So femtosecond flaps. In terms of dealing with presbyopia now, there are some relatively new things on the horizon with laser. This is 2 or 3 years down the line now, but this is an intra-core procedure. And the concept here was that the surgeons used the femtosecond laser to cut rings into the cornea. I'm so sorry. And those rings allow a little bit of bulging to occur in the very central 2 millimeters or so, which is meant to give you a slightly multifocal cornea. Just in case this doesn't work, I'll just try and advance that. There's also another way of doing it. So sorry about this. I'll just leave it there for a second if you don't mind. Which is actually directly reprofiling the cornea, and that's a technique called supracore. And that's a little bit gentler on the cornea. It's trying to create a slight bulge in the center, much like a multifocal IOL with a central reading ad, to give patients slightly better reading, intermediate vision particularly. I'll just move this on. I've got a feeling there's a glitch with that particular slide. So, finally, for those in the audience who want to know how to avoid problems completely, who do you turn down? I would recommend the following. Now, I don't know all there is to know about the software for the laser, but I've got a fairly good idea, and I've been sort of immersed in the whole thing for 22 years. But if somebody comes in wanting to know which version of software you've got, and is it version 5.13 with a special release, that's it. Watch out for the physicists. People who've got very specific requirements. For example, if I feel I'm having a tough time, I can ask them how often they went back to their optometrist for new glasses after they'd had new glasses prescribed. Because normally, of course, you'd ask the patient to try them for a couple of weeks, but these are people who give you just as much a hard time as they would give us if we were foolish enough to treat them. The license applicants are interesting because they just want to get better than 660, 636, unaided. If you don't get them to what they were with their very best optical appliance, then they want to know why. And you also want to avoid, in as polite a way as possible, patients who are never ending in their questions. You've gone through an hour with them. I don't really, truly, I don't know how the commercial clinics manage. Because if they had the patients that come and sit with me, they're just asking endless questions the whole time. And they'll often produce some sort of printout from the internet. So we've talked about the low myopes. That's important. You should not really treat a -1.5, 45-year-old myope unless he may be a professional golfer or a professional driver. He got some really motivating factor. This we've talked about already. By the way, it's usually the boys that come along accompanied by the mum. People who say this, people who don't quite realise that 99% is not 100%. And if they're the 1%, how are they going to react? And then, of course, those who sort of talk you around to the statistics that they want to hear. And I'll just leave that on for a second or two. Because patients are very selective in what they hear. They'll remember important things and they'll haunt you with that, but they're very, very selective in what they recall. And then, of course, there's the good old hot potato of communication breakdown, where we've all got it completely wrong. Like the young lad, mid-20s, because bear in mind, nobody's younger than 21, so they're all 21 or older. And the girls, the nursing staff, told him to wear the goggles while he was sleeping so that he wouldn't stick his finger in his eye or rest on the pillow. So he went home and had a beer in the afternoon and slept on the couch. Because it wasn't in the night time, he didn't think the goggles counted. Or the lady who had super glue in her handbag, along with her eye drops, and managed to put the wrong one in. Hard to imagine. I tell them that it won't be perfect. In some instances it is. I mean, the vast majority of patients are very pleased with this. Some of this is obviously tongue-in-cheek. But patients need to know that it's not an exact science. We haven't got a handle on corneal wound healing where we can titrate the result and make them perfectly emmetropic every time. I tell them that my retreatment rate is 3%. That ought to tell them that 3% of patients have to do a bit more to fine-tune the result. It's not 100%. And that's because of the biological system that is the amazing human cornea. We won't heal in the same way one to another. The two eyes don't heal in exactly the same way very often. And two eyes with two different prescriptions often don't heal in quite the same way. I tell them that they will need reading glasses to prepare them. They may get away with it if they're reading a magazine in the garden and the sun's out as it was the last 2 or 3 days. Tell them if they've got, 4 diopters of oblique astigmatism. If they wear varifocals, be very careful, because the varifocals, for all they're not perfect for everybody, at least they do have a range of vision built in, and they often miss the intermediate more than anything else. Then you have unhelpful comments by your friends and colleagues. Like, for example, you have some corneal scarring. I distinctly remember a patient of mine who was very, very difficult to treat. Because this is being recorded, I will not say any more. But he was very difficult to treat, and he did have a little bit of haze towards the edge of the flap. He came and saw me many, many times. We treated him as well as we could. He ended up with a fantastic result from the visual point of view, and because I didn't want to worry him, I didn't want to make him more anxious, I didn't tell him about this little bit of haze at the edge of the cornea. So he went to his optician for a review, and the optician said, "You've got corneal scarring. You better go back and see the ophthalmologist." When he came back to see me, he didn't tell me. He said he'd come back for a routine check, and he then just let me go through the whole thing. Again, I've got the diagrams in the notes. I'd seen this little bit of haze at the edge, and when he was leaving, he said, "So that's fine, is it? That's all okay?" I said, "Yeah, it's fine. You're doing very well. 6.5 one eye, 6.6 the other. Very good result." "Oh, are you sure?" And then it all came out. What about the patient who was told by the optometrist, "Well, it hasn't really worked for you because you've still got half a diopter of myopia in one eye"? The patient came back for their 3-month checkup and told me this. They'd been -8 in each eye before we started. Why bother to have laser surgery for myopia or for high myopia? Because you're in your 40s, you're still going to have reading glasses anyway. That completely misses the point. These patients wake up in the morning with usually 20/20 vision after we've finished. And yet somebody's saying to them, well, why bother to do that? Because you're still going to have reading glasses. It's very interesting, the perception. And of course, the good old, you can only manage 6/5 unaided now. I had a solicitor, a husband and wife team, both solicitors. She needed LASIK and he needed LASIK. And he was 6/5 right and left with his best corrected acuity before we did the treatments. He was about -4, which is a very good prescription to treat. He came back 6/4 unaided in the right eye and 6/5 unaided in the left, and he wanted to know what had gone wrong with the left eye. Oh yes, the good old statement that they can't treat astigmatism or hyperopia. Well, I had my treatment 11 years ago, as you now know, and I had 3 diopters of astigmatism in each eye, oblique. Quite a difficult prescription to treat. And contact lenses, of course, are proven, and they have been around for a very long time. Safer, I'm not so sure, because the infection rate with LASIK is less than the infection rate with contact lenses. But you're actually comparing apples with oranges to a degree, because the infection rate with laser is only for the first week or 2. Once you've gone past that point, you really should not pick up an infection beyond that. Contact lenses is more of a war of attrition. You know, you're going through a 5-year period to get the statistics. Finally, what about the patient who very carefully folds tissues and rests it on the slit lamp? Now, we don't have the paper tissues anymore because health and safety or infection control have told us that they're not good to use. Bits of water, fluorescein drip onto the tissues and the tissues get a bit wet. Eventually, you know, so we just wipe down the actual chin rest with a spray, an alcohol wipe. What about the patients who bring their own tissues with them? Or they do it for you. I only want perfection, or why would I bother? Well, of course, that's the sort of person who doesn't swim very often. They don't play golf in the rain. I was always amazed that people played golf in the rain. I'm not a golfer, as you can probably tell. And people kept saying, well, when I play golf in the rain, you know, I can't see so well with my specs. And I assumed that it had started raining when they were halfway around. But these are people who actually go out to play golf when it's raining. It's really our fault. The newspapers and certain sections of my profession and certain sections perhaps of your profession will sort of go on about how wonderful this treatment can be. We've only got ourselves to blame when it comes to trying to handle patients' expectations. One patient complained that I'd spent longer looking at her left eye, and that's why she wasn't going to go ahead with the surgery. And this is the good one about the questions. And then after all this questioning and an hour's gone by, then you find that this patient brings out a long printout from the internet, 24 pages or whatever, 24 pages, and she wants you to go through them all. It's not always a she, by the way. That's my mistake. Have you ever been sued successfully for more than $30,000? Well, it gives you a clue because it's in dollars, of course, so you know where that's come from. At that point in time, I call time. They've had enough of my time. My time is not infinite. It's very precious. And so if I've given them everything that I can up to that point, and they've seen my optometrist, I have 3 optometrists working with me. They're all excellent. They're all staff at City University. They're lecturers. They really are top-notch. And if amongst the 4 of us, we haven't managed to satisfy this patient's queries, then they are welcome to come back for a second consultation. I certainly don't charge for that. But we do say that they'll need more time. We don't just go on regardless. So even with the very latest technology, we still haven't got to the point where we can promise a perfect result. If you want to know what happened to me, by the way, I had compound myopic astigmatism with these 3 diopters of oblique cyl. My left eye is 6/5 unaided, truly, but I can't read with it. And my right eye is about -0.75 negative cyl, and I can read with it as long as the stuff's not too small. So I've got a slightly funny pseudo-mini monovision, and that works very well at work. Of course, at work we're using microscopes, but just for reading a set of case notes, I can manage that perfectly well. I've got reading glasses at home, which I use for reading the Sunday papers or whatever. But for me, that's worked extremely well. The only slight downside is that my dominant eye used to be my right eye. I think over the years, I've just forgotten all about that. It hasn't made a difference. Watch out for unrealistic expectations. And then this slide probably says it all, because there's no question that in surgery, especially if you could regard it as cosmetic surgery, Personally, I've benefited immensely from my treatment, and I wouldn't say it was cosmetic. I wasn't too fussed about spectacles. I used to play a lot of squash, could never wear contact lenses because of the astigmatism and tight eyelids and a slightly obsessive nature. And so for me it's worked very, very well, but there'll always be somebody somewhere. It doesn't matter if you're the most experienced laser refractive surgeon in the world, they will not be happy. Now I do apologise that that's off the screen. So this slide means nothing to you, except what it says at the bottom is, what do you mean it's a bit muddy? Thank you.